Instead, we believe in safety before depth, curiosity before correction, and connection before conclusion. Because we recognize that many of us, we find it very difficult to discuss this topic. It's very emotionally sensitive. Our goal is to create a space where people can feel seen, heard, respected, and supported as we navigate these conversations together. So tonight, I invite you to listen with compassion. And Dr. Vidrine, thank you so much for taking the time to come and share with us this evening. We truly appreciate it. Just a few questions for you. If you could just share with us your background in terms of um, where you're from, where you grew up, just a sense for our audience.
Well, first and foremost, hello, everyone. I am Dr. Dominique Verdrine, and I am very thankful for having this opportunity to be invited here by Faith and Family Circle. Um, I am a Haitian American, Christian, born and raised in Brooklyn, New York. And
Mm,
so while I'm from Brooklyn, New York, I'm hailing from Greenville, South Carolina, which is where I'm located.
okay. All right. So, based on the bio I read about you, it mentions that your work spans therapy education,
Mhm.
research, and community healing. What first inspired you to dedicate your life to supporting individuals and families?
My own family. I think I saw there was a lot of love. There was a lot of love. There was a lot of resilience. However, there was a lot of pain also. Pain that would often go neglected.
Mm-hmm.
Um, because my parents, I'm second generation, so my parents are first generation. And so coming here from Haiti, there was a lot of expectation of um, pushing through to be able to make way for the next, um, for those that are back home that you have to bring here. At least that was my family story. So chain migration was very big in my family. And there was a lot of family members who they just left their kids and said, I'll be back. I'm going to buy something for you. And then 3 years later, they're
Wow. Mm-hmm.
rejoining them here. They
Mm-hmm.
were trying to make what's in their belief was the best decision. And so just seeing some of the pain and hurt that has happened
Mm-hmm.
that doesn't often get acknowledged, at least in my family. And so I've seen that in other family members, other families that are also of immigrant backgrounds to this country. So that's been really a big reason as to why I entered this field.
Thank you so much. There's so much more I could ask you, but I am going to just allow us to move forward in the interest of time. And again, I just have to tell the audience this, that you agreed to do this in days. And I'm just so grateful for my friend who said, no, we have to figure this out after we had a last minute situation where the person who was supposed to present had a death in her family. Very sad. And so we are just grateful. We definitely, of course, understood that she had to do this, and we're grateful that you decided in such short space of time to join us this evening. Thank you so much.
You once again.
All right, everyone. At this time, Dr. Virginia is going to present on the topic depression and withdrawal. And then after that, feel free to ask your questions. And if you feel like there's a question you have, feel free to put it in the chat while she's presenting. We'll be more than happy to go through all of those as well. Thank you so much.
Yeah, the topic tonight, we're going to talk about depression and withdrawal, recognizing the signs. So I like to just have some community agreements. This is something I usually do just to make sure that we're on the same page as how we show up in this virtual space, which I like to call a container. I ask that we agree to be fully present. And for me, that's not paying attention to, oh my gosh, the to-do list that I didn't get to, right? Just being fully present here in this virtual space, being kind. And for me, that's extending grace to ourselves. I really do appreciate what Andrea, you stated earlier about recognizing that we come together to listen, learn, reflect, and to grow, and that no one expected to know it all. So I am not the purveyor of all knowledge. So it's my hope that you will extend grace to me too. Um, Please be open. I ask that we be open and receptive. I like to say, I call it having a teachable spirit with regards to what we're going to hear tonight, not just from me, but from each other as well. Right? We may have different perspectives, and just being open to hearing those perspectives, I think, can be very instrumental to the discourse we're going to have tonight. I also ask that we share this space in an equitable way. And what I mean is when we open up the floor for discussion, that we leave room for everyone to be able to share their thoughts or to ask questions. I do believe there's collective wisdom that's in this space. And so I do think it's good to be able to tap into that to enrich the conversation we're going to have tonight. I also ask that we be our genuine selves, be authentic, and I ask that we be brave because sometimes people want to say just perfectly or just right. And then by the time they get it together, we moved on to a different topic. So I just ask that we be intentional to recognize that, first draft is okay. Okay. So those are the community agreements that I'd like to ask that we adhere to tonight. Next slide, please. Thank you. So today, what is my hope is to help you all to learn and understand what depression is. We're going to share some statistics about depression, signs and symptoms of depression, the risk factors of depression, why some people choose not to get help, and then some of the available ways in which we can manage and treat depression. So what is depression? So when we're talking about depression, it's a mental health disorder that significantly affects a person's thoughts, feelings, and actions, often leading to distress and impairment of one's level of functioning. Symptoms of depression usually last at least a week. And are cyclical. And what I mean by cyclical, it's symptoms come and go over months or even years. And it's considered to be an invisible disorder. And what I mean by that is because it impacts an individual's thoughts, feelings, and actions, your thoughts and feelings are often not seen. It's not something that you can see. So oftentimes people think that the issue is a matter of decision making. So you're not really depressed. You just need to decide to do different, right? You just need to snap out of it. And if you did that, then you wouldn't have these issues. And so oftentimes people think it's more of a decision that someone is making to be the way that they feel with regards to depression. And so it's considered the invisible disorder. So what are some stats I think that are important for us to pay attention to? And this is according to a Gallup National Health Wellbeing Index of 2025. Current rate of depression in the United States, as of 2025, 19.1% of the US adults currently have or are being treated for depression. So that's approximately 51 million Americans, which is a high number. And then 29% of US adults report having been diagnosed with depression at some point. Nearly 1 in 3 have been diagnosed with depression. And so with the Gallup, the question that they ask is, they ask individuals, have you ever had a physician tell you that you've had a physician or a nurse tell you that you have depression? So that's how they came up with that information. 33% of lonely adults have depression versus 13% of non-lonely adults. So 21% of US adults report significant daily loneliness, right? And we see that increasing. So there seems to be a direct correlation between individual adults who are lonely and having increased level of depression. The average delay between symptoms starting and individuals actually getting help tends to be 11 years. So that's also important for us to note. Next slide, please. Depression is believed to be the leading cause of disability worldwide. Right? So it's really important for us to pay attention to. According to the Center of Disease Control, among those with depression symptoms, 87.9% reported difficulty with daily activities. So it does impact individuals' functioning, and 31.2% reported extreme difficulty. So we have research that's showing that when individuals are depressed, it negatively impacts their daily abilities and functions. Adolescents between the ages of 12 and 19 show a prevalence of 19.2% of depression. And this is, like I said, according to the CDC. Depression prevalence increased 60% from 2013 to 2014, which was at 8.2% of the population was experiencing depression. And then it jumped to 13.1%, the prevalence of depression in 2021 and 2023. The highest depression rates amongst ages 12 to 19, and then the lowest depression rates tends to be amongst individual ages 60 and above, okay, in the United States. And then depression symptoms by groups, will notice that 18.3% prevalence for non-Hispanic multiracial individuals in the US, 13.6% for Black in the US, and then 11.5% prevalence rate for whites in the US, 11.3% rate for Hispanics in the US, and then 7.4% rate for Asians in the US. So it's definitely a serious issue that we want to take and pay attention to and attend to, especially in the United States, because we're seeing right now, the latest research that I saw stated that individuals in African American community as well as the Hispanic community, the rates of depression are increasing at an alarming rate. Next slide, please. So these are just some symptoms of depression that it's really important for us to pay attention to. So you'll see here we have low mood, we'll have a loss of interest and pleasure, loss of energy, sleep disturbances, changes in appetite and weight, difficulty concentrating and making decisions, feelings of hopelessness and guilt, physical symptoms, feelings of emptiness and loneliness, belief in the inability to change the situation. So there's the ways in which I like for us to have a better understanding of these symptoms. And so on the next slide, you'll see that I talk about the ABCs of depression symptoms. Next slide, please. So the ABCs. So A stands for affect, which is really one's feelings and emotions. B stands for behavior, one's actions. And then C stands for cognition, which is one's thought processes. So when we're looking at understanding depression, because we know it's a disorder that impacts individuals' thoughts, feelings, and behaviors, it's important for us to pay attention to how this shows up, right, in individuals. So common symptoms that we see when we're looking at the affect, the emotions, the feelings that people who commonly have depression experience. They express feelings of sadness, guilt, emptiness, or hopelessness. There can be anger, feelings of irritability or frustration over small matters. Likewise, when it comes to one's actions, their behavior, we'll notice there may be a loss of interest or pleasure in most or all normal activities, like hobbies or sports that they normally would engage in. We'll notice social withdrawal or self-isolation. There'll be unexplained physical problems, such as back pain or headaches, tiredness, and lack of energy. So even the small tasks take extra effort or become really difficult to complete. There'll be sleep disturbances, including insomnia or sleeping too much, as in hypersomnia, or sometimes sleeping but not being able to sleep throughout the night, right? Sometimes just having difficulties falling asleep for extended period of time. Reduced appetite and weight loss, or increased cravings for food and weight gain. So these are some behavioral changes that we'll notice when someone is experiencing depression. Now, with C, cognition, one's thoughts or thinking processes, what we'll see is that individuals sometimes report experiencing difficulties concentrating. They'll have a hard time thinking. Sometimes their thinking process has significantly slowed down. Sometimes the individual reports having difficulties making decisions. Sometimes they have difficulties remembering things. They may have frequent or recurrent thoughts of death, suicidal thoughts. Sometimes they may attempt suicide. Unfortunately. So these are some of the ABCs of depression symptoms. On the next slide, I'm going to talk a little bit more about some common withdrawal symptoms. So this is when you'll see people sometimes who are dealing with depression may have the urge to pull away. So activities or individuals they used to connect with on a regular basis, they may not do so as much. So they're not coming to Bible study like they used to. They may not be returning people's phone calls like they used to. They may start shutting down. Social isolation, this may be where they self-isolate. You'll notice everyone's downstairs, we're enjoying a family night, movie night, and the other person who's dealing with depression stays isolated in their room. They may have the shades or the curtains pulled closed, and so it's dark, no light coming in. Rumination. And when we talk about rumination, this is typically where individuals have brooding thoughts or dwelling on negative self-talk. This is where they tend to have stinking thinking, is what I like to call it, or unhelpful thinking styles. This is where somebody might be at the grocery store and they're on the checkout line, and they'll notice that the cashier smiles at the customer in front of them, and then the cashier doesn't smile at them. And then they'll think to themselves, they must not like me. They must think I'm ugly. They start having these negative thoughts that are not true, but the assumption is that they're the issue, they're the problem, and this is why this is happening to them. And then they can ruminate on this. They can consistently think about these things well into after leaving the grocery store, well into getting back home from the grocery store. Also, doom scrolling. This is how sometimes people tend to zone out and consistently checking social media. And they can spend hours upon hours there. And sometimes people will say, oh, this is just what I do for fun. But really, we have to do a deep dive to figure out, is this activity serving to distract or to numb the individual from feeling feelings themselves? Or is this a way for them to connect to other individuals? So that can be another way in which people withdraw when they're experiencing depression. Operating on autopilot. This is where people just are doing things like they normally do. They have a routine and it's just go, 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 go. And they're not stopping to really enjoy different activities of life. They're not really being creative. It's just, I got to get this done. And they're just operating on that period. Excessive engagement in unsafe behaviors. That's another way in which people also withdraw when they're experiencing depression. And so you'll hear sometimes people may engage in excessive drinking of alcohol, engaging in risky behaviors such as substances, using substances. Or you might see sometimes people are engaging with crowds that they've never really engaged with before, going to events that are not really something that's within their interests or safe for them. Sometimes you might see hyperactive behavior and sexual behaviors and stuff along those lines. So these are some common withdrawal symptoms that individuals suffering from depression might experience and that you might see. The risk factors to depression. So there are multiple risk factors to depression. Sometimes people like to say, what's causing the depression? And we don't really have just one thing. We do believe that we see that there are things that are highly correlated. And so some of these include biological factors. So family history. If there's family members in your family that have had a history of depression or similar disorders, there is a heightened likelihood that you may be predisposed to having depression. Doesn't mean that you'll have it, but there's a predisposition there that could be. Psychological factors, such as if there's early adverse life experiences that you've experienced, early loss or neglect, right? So when we talk about adverse life experiences, sometimes it can be if there's been any forms of abuse or if you've experienced a natural disaster. When we're thinking about pandemics, we just, we're dealing, fortunately coming out of it, but dealing with the pandemic of COVID-19. These could be some psychological factors as well as environmental factors. Some of the environmental factors that can be risk factors for experiencing depression include poverty, unemployment, systems of oppression, racism, sexism, homophobia, xenophobia, ableism, and unfortunately, the list goes on and on. Social isolation, stressful life events, so like changing a job or losing a job, changing schools, moving to a new location, the unexpected death of a loved one, divorce. So these are some environmental factors that can be risk factors for experiencing depression. And then also, as I stated earlier, engagement in risky behaviors. So excessive use of drugs or alcohol. And sometimes it doesn't even have to be excessive. For instance, people can experiment, and sometimes this experimentation can be very problematic. So those are some risk factors when we're talking about that can influence depression. Next slide, please. Why people refuse to get help for depression. It's important to note there are several reasons. And so some of these include, but are not limited to, financial constraints, right? So out-of-pocket costs for getting help. And when I'm talking about help, I'm talking about just if you want to see a psychiatrist, if you want to see a therapist, it can be costly. Even if people have insurance, it can be costly. Sometimes people don't have insurance, and that's even more costly. Psychological barriers, right? So this is where we may have fears of being judged for, especially when there's a stigma, right? So sometimes you'll hear people say, I'm not crazy, right? There's a stigma that if you're getting help, right? If you're seeing a therapist or a shrink or a psychiatrist, then you must be crazy. So that's part of it. Sometimes it's the belief people have about therapy and psychiatry and thinking it's not going to work. So I'm not going to go there and get help if I don't think it's going to work, right? Sometimes people don't realize that they actually are dealing with depression because they've been doing this autopilot for so long. They've been operating on autopilot that, what do you mean I'm depressed? No. And there is such a thing as, functioning with depression. Right. And then sometimes people believe, you know what? I just need to try harder. I need to try harder. I need to snap out of it. If I could just do that, once again, thinking that has to do with having a decision, making a decision to do better and not to feel this way. So that can influence, these are some psychological barriers that can influence people not getting help. Access to adequate care. This could be oftentimes noted in underserved communities where there's just not enough resources, accessible resources for people to access adequate care. Practical issues, sometimes it's a matter of transportation issues. Sometimes people who work and then, clinics and or centers, community health centers close at 5 p.m. You get off of work at 5. There's no way I'm gonna get there in time to be able to see my therapist because their office is closed. Some therapy offices close at 5 as well. And so just practical issues around transportation issues. If I don't have a ride to get to the office in time, or if my schedule doesn't permit for me to be able to go to the therapy center or community health center in a timely manner. And then cultural and language barriers, a lack of culturally sensitive and responsive care. We know that that is an issue that also influences and impacts people's ability to want to come in to get services. For racial and ethnic minorities, there's been a history of mistrust with the behavioral health system, with the medical system, due to previous mistreatment by said systems, right? And so these are some reasons why people may not get help for depression, right? And specifically when it comes to the uh, the faith-based communities, sometimes people don't get help because they think all I need to do is pray about it. And if I pray about it and I have enough faith, then this would be okay. I wouldn't be dealing with this. So I just need to pray harder and have faith, and then I won't have to worry about the depression. So when it comes to treating one's depression, it's important to note that, especially for depression, psychotherapy, also known as talk therapy, and medication management tend to be the go-tos for trying to address symptoms of depression. But a combination of psychotherapy and medication management is thought to be the most effective way to address depression. Next slide, please. So what does therapy entail? So it's important to note therapy can be individual therapy, you can have family therapy, you can have couples therapy, you can participate in group therapy. Usually, therapy sessions on average tend to last 50 to 60 minutes. And the duration of therapy process is going to be based on what it is that you're dealing with, right? The severity of the issue, the complexity of the issue. So sometimes there's short-term therapy, um, which can entail dealing with immediate issues, or long-term therapy, which deals with long-standing complex issues. And when we're talking about psychotherapy, it's really the process of meeting with a licensed clinician, a licensed therapist, to talk about and work through problematic issues, behaviors, feelings, beliefs, relationship issues, and then addressing any psychosomatic responses. And so it's important to note that when we're talking about therapy, I'm a big proponent for individuals seeking therapy from a licensed clinician. These are individuals who've had to meet certain standards, to take a national exam, to be prepared to be able to provide ethically sound and quality services to clients. So there's different types of therapy, psychotherapy, there's cognitive behavioral therapy, and that's the most evidence-based. That means it's the most researched type of psychotherapy that's been out there. There's psychodynamic therapy, and then there's family systems. But cognitive behavioral therapy approach has been known to work significantly well in dealing with issues of depression, treating and dealing with issues of depression. I did want to share some resources in your local community. I'm not well versed in your area, but this is some of the stuff that I saw that they have. Nuvance Health Medical Practices, Behavioral Health, in Carmel, which I believe is a town that's not too far from Summers. And then there's TriStar Behavioral Health in Mount Vernon. And then there's Westchester Community Health Center, also in Mount Vernon. Next slide, please. Just want to say thank you once again for giving me this opportunity to join you here, Faith and Family Circle. And I'd like to open the floor for any questions that you may have.
Thank you so much for that. That was just so much to to take in, to be honest with you. I am going to see, do we have anything in the chat? No, we do not. Are there any questions for Dr. Vidrine?
I have a question. How do you know which form of therapy is the best for either the individual or the situation or the period you are in your life?
That's a very good question. And so usually what happens is we do have assessments tools, questionnaires that we ask to assess the severity of a client's symptoms of depression. Like, how severe is the depression? Is it mild? Is it moderate? Is it recurrent? So we want to pay attention to that to see whether or not they would need to possibly go ahead and see their primary care physician or their psychiatrist to assess whether or not they would be beneficial for getting some medication to get them to a baseline where they can get sometimes some immediate relief and then be able to participate in psychotherapy. Now, as it comes to the psychotherapy approaches, sometimes we can do a combination with regards to utilizing CBT, which is cognitive behavioral therapy approach, and in addition to some other theoretical orientations, which for me, I tend to do a combination of CBT when there is depression because of the fact that it's so research-based and is shown that it's been very effective. So really it's going to be, for me, it's a case by case, needing to know the severity of the depression, which is going to also influence, what direction we go, and then also how open the client is. So some clients are not receptive to medication management. And so at that point, I do tell clients, well, we can still, and I'm not Usually I like to hold off if can from having to utilize medication at the first course. But sometimes if the symptoms are so severe and we need to get this person to a baseline, then I'll go there. But there's also behavior modification. There's also ways in which we can engage in journaling about what's happening. So that would be some of the ways in which, for me, I would work on determining what course of action to take with a client who's dealing with depression.
Thank you. I think I see a question in the chat. In one of your slides, it states that depression is the leading cause of disability. Please explain.
Yes. So it's the leading cause of disability in the sense of it's also connected to other disorders. Like there's a high correlation. It's between individuals who have depression may also have a high level of anxiety. And so we know for a fact that it does negatively impact people's functioning. That's the issue with depression. So sometimes people get, when they see these symptoms like, oh, I've had sadness, I have feelings of guilt, I have this. It's not so much that you don't have it. It's a matter of you having those symptoms and then them having these symptoms having such a significant impact on your ability to function and do your daily activities. And so depression does that, has a high level of impact on people's daily activities. And so seeing that in the research with and how many individuals have it, like 51 million. Okay, according to the Gallup poll research, and CDC is stating that that's the amount. That's alarming of individuals who have who are dealing with depression. And so depression can also come on too by, I didn't put this in there in the PowerPoint, but also if there are some physical concerns or medical conditions that people have, sometimes mood disorders can lead to individuals having depression as well.
Thank you.
I have a question. With your years of experience that you've had dealing with individuals that are depressed, and if they need to go on medication, do these individuals have to stay on medication for life? Have there ever been a moment where you have concluded that this individual does not need to be on medication anymore and they can live a more normalized life without depending on the medication to help them get through their daily lives at that point? Have you ever dealt with that or experienced that, or had anyone that would not necessarily have to stay on medication long term?
And that is something that I talk with my clients about. A lot of my clients prefer not to be on medication. And so my thing is wanting them to understand, okay, what's causing the behavior? Let's see what are some factors that are influencing what you're experiencing at the moment. Now, sometimes it could be chemical issues, right? And so that's where, I am not a psychiatrist. I am so that's not within my scope of practice. So that's where I refer to a psychiatrist, or I refer to their primary care physician, who are board certified individuals. And that's what they have been trained to do, so they can assess how best to support an individual who's having depression with medication management. Now, I do tell my clients, no one can force you, right, to take medication. However, it can be very helpful, but it's important for you to be an advocate for yourself. So asking questions, having a good understanding of what the medication does to your body, what are potential side effects of the medication, so that you can be well informed and can be paying attention to noticing the differences when your body is on the medication, when you're not on the medication, how you're feeling when you're on the medication, what kind of thought processes are you having when you're on the medication, when you're off. And so there have been clients, to answer your question, there have been clients that I've worked with who started off at times with medication, and then with help, as they started feeling better, they were able to implement some of the strategies that we talked about in therapy on a more consistent basis. And then with the help of their psychiatrist, they were able to titrate themselves off of the medication. So that does happen. It doesn't have to be lifelong, because sometimes once again, what is causing, what's impacting the individual to experience the depressive symptoms is really important.
Thank you.
You're welcome.
So very
Hello,
good
good
question.
evening.
Go ahead, please.
Yes, hi, good evening.
Good evening.
Good evening.
Thank you for your presentation. The statistics were very eye-opening, and it led me to this question that I have. How do you approach, or what's the best approach that you could suggest to someone that you think might be displaying majority of the symptoms and you think would benefit from some intervention of some type of therapy? What's the best approach?
Yes. So in working with someone or wanting to speak to someone about potentially getting help, what I like to do is I like to just share with people that mental health, right? When we talk about mental health, it's really important to know that our mental health exists on a pyramid, right? So sometimes you're like, oh, you know what? No distress. I don't have any problems right now. But sometimes we could experience distress. I feel stressed out, have a lot going on. We're experiencing some mental distress. For instance, um, I'm just dealing with trying to buy this house. It's been a lot, very stressful. That's to be expected. You're going to experiencing some stress with getting all the paperwork or what have you. Then there can be, you know what, I'm having a mental health problem. This has been a bit tough for me. I've experienced really, hard times with the fact that there's been a loss of my job, or we don't know anybody here. We just moved and trying to, adjust and acclimate to just being in this neighborhood. So that's been very distressing. And then sometimes there's individuals who are experiencing actually a mental health disorder, right? We have a large population in our society who has this, who are, how would I say, have more so of a mental health issue problem and not necessarily a disorder. But people often think, anything depression as a bad thing. And so what I try to tell people, or what I would recommend is to ask them, if they're open to talking with you, that you're just noticing, things have changed a little bit with them. And so you're wondering, have they noticed the change? And just saying, the reason why I ask is because I'm noticing this has been something that's uncommon for you. And so I was just a little concerned, a little worried. But I always try to ask people their permission if I could share something with them. So depending on how close you are with that person. And then after that, if they're open and receptive and say, yes, things have changed a little bit, be like, I don't know if you've had this experience yourself, but I often tell people, so one of the things that I've had to deal with personally has been with anxiety. And so people don't often assume that about me, but so when I see it in other individuals, I can share that story with them, share my personal experience and say, for me, I've struggled with this and it's been very instrumental for me to be able to get help. So I've been able to see a therapist. And so I share my story and letting them know. And then sometimes that makes it a little bit easier for them to hear me when I say, maybe something you might want to consider talking to somebody, not telling you what to do, but it's an option. Because sometimes it can be really challenging having these feelings and not knowing what to do with them. So I try to be curious. I try to ask them their permission to be able to share what I'm noticing. And if they're receptive to me saying that, then I'm going to say what I see. And then also state, I think it's important to just think about, reaching out to speaking to someone who could potentially help. The challenge that sometimes happens, I've noticed with family and friends, is that people will sometimes say, well, I could just talk to you, right? And so what I tell people when people say that is, you could, however, I'm not, and this is not as a therapist, but I'm not trained to be able to support you in the way that I think you would best need. So I wouldn't want you to tell me all this and then increase your level of frustration because I'm not really equipped to be able to help you as I would like to be. Does that help answer your question?
Yes, yes. Thank you. Beautiful.
You're
Thank
welcome.
you. There's a question in the chat. It says, there's
Oh.
somebody I know, young adult, and I think he needs to see a doctor or, I'm assuming, counseling or to talk to somebody, but he doesn't want to. How do you think we can make him go to see somebody?
So if this is somebody that's a family member, because a
Mhm.
lot of times I experience that, family members who are concerned about a family member who they think would benefit from going to therapy, I often tell people, you can go to therapy yourself, right? And then you can say, it would really help me if you come with me, right? Or if there's a group session, a group therapy session that you find, or some support group, you can be the one to go and then ask your friend to accompany you. But in all sincerity, the other thing that happens, I've had parents who initially bring their kids or bring their reach out to me wanting their adult children to see me or their adolescents to see me. Now they have more leeway with their children and adolescents, the young children and adolescents. But in all sincerity, I tell people if that person does not want to, they can come and still not be helpful. Right? So they have to be willing to come. And so forcing them to come is not going to be helpful or beneficial to them. They have to be willing to at least try, right? And so I tell people the best way I know is to you come and then you ask them to come with you. So that's what I've done with some of my clients. When they're coming to me, they're like, I really want to get my husband in, but he doesn't think he needs any therapy. I really want to get my wife, but she doesn't think she needs any therapy or what have you. And I said, well, just invite them in for a conjoint session. So they don't have to be the client. They can just come. And
Mhm.
then the therapist can ask them questions and, initiate some understanding around what their presenting issue could be or what have you.
As you're talking about that, what if the situation is where, whether spouse or adult child, it is so severe that it's impacting their ability to work, impacting their ability to even take care of themselves, take a shower, because
Yeah.
I mean, depression, you know, how do you really handle a situation like that?
So a situation like that, I don't know what the regulations would be for the state of New York because I'm not
Mhm.
there. But in situations like that, where you're concerned about their well-being, like you're concerned that they're not able to take care of themselves, their depression is so severe that they're not able to do that. There are ways in which the courts can get involved. So in South Carolina, what we do is that a family member can come to the mental health and then speak with with the therapist or a psychiatrist and say, this is what I'm concerned about regarding this person. They're not bathing, they're not eating. I'm really concerned about their ability to take care of themselves. And so then there can be commitment papers that can be completed by the psychiatrist, sent to the magistrate, and then the courts can decide to have that person picked up and brought into the hospital for a 72-hour hold to be assessed.
Mhm.
Once again, I am not aware of that process in New York State, but it does occur across all states that there is something, I don't know what it's called in New York State, but that is what normally happens here in South Carolina. So something similar like that does happen, or can happen, I should say, in the state of New York.
It does. It so happens that you can actually, if there's concern about the person's health, you can actually call 911 and
Mhm.
they will come. And after that, they'll take the person to a facility. If the person refuses to get support, then there are the courts, treatment over objection. So there are processes. The truth, though, is family members find it very difficult to make decisions like these because it really put a strain on the relationship. And so those are very hard choices to make.
Right. Those are very hard choices to make. And at that time, this is why family therapy is also helpful,
Mhm.
to help people navigate through the process, right? I think it's important to be aware of what the process entails. I try my
Mhm.
best to help clients know this is what can happen. This is what you can expect. They can do a 72-hour hold. That doesn't mean it's going to fix everything. Doesn't mean that your family member is going to take the medication and adhere to it. So
Mhm.
these are some things to expect, and how are you going to handle it moving forward?
Yeah.
So it's important for families to participate as well and get support because it can be very challenging.
Yeah. A question in the chat says, what is your opinion on the overdiagnosis and medicalization of normal suffering, treating grief, stress, and transitioning as depression? Also, do you see your Christian experience as a source solution?
Yeah. Great question.
Mhm.
Um, so what I will say is, yes, there is, unfortunately, in my opinion, there is an overdiagnosis.
You can't put them like that.
Got you. Mhm.
There is an overdiagnosis and medicalization of normal suffering, unfortunately. Sometimes I think this pop psychology happens where we have all this like new trends that are coming in. And so everything becomes too much. And so then what happens is people don't know how to handle um, normal life experiences, right? So
Mhm.
then that becomes very, very challenging. Um, as per, do I use Christian experience as a source of solution? So if you go on my page, I do inform people that I am Christian. However, while I'm Christian, I'm not a Christian counselor. So I didn't go to seminary school. I don't have any of the pastoral counseling experience, right? So I always make sure to let clients know that. However, I do tell them and I let them know that if they want to, they can utilize this is a space, meaning therapy space, where they can bring in their faith if they like, as a source, a resource for them in the therapy room. So that's the way in which I do that. It's more so client led. So if the client says, yes, Dr. Verdreen, I would really appreciate to utilize my faith as a resource in, my therapy work with you. So sometimes there's scriptures. If I know they're open to that, I have scriptures that I can lean on that I can bring to their attention. And we can talk about that along those ways with the understanding that they understand that I am not a pastoral counselor. I don't have any seminary background. So yes, I do use my Christian experience as a source of solutions, primarily the client's Christian experience, because it's really about them, as long as it's not
Thank
pathological. But that
thank you.
caveat as well. Mhm.
Sister Yvette placed in the chat that 988 is the mental health number here in New York State. So just for those who may need that number, it's 988.
Yes, and that's a national number too, national
Okay,
hotline. Mhm.
okay. So a question I have is this. I know many family members who feel very strongly that therapy is a waste of time.
Mhm.
The response is when I was growing up, we just had to tough it out. And you mentioned that. And the young people these days are weak and wimpy and a lot of that kind of language.
Mhm.
How do we get to a place where we can help people to truly understand the value of counseling and therapy, and also recognizing that sometimes we ourselves who grew up with that kind of statement and conversation may need to stop for a minute to reflect on what our needs are. Because oftentimes, as we hear the conversation, people will tell stories and you will hear them comment about their resentment
Mhm.
towards their experiences. How do we, you know, get people to a place of appreciating and understanding the value of therapy?
Yes, I think for me, what I think has been helpful for me is always asking people about where does this come from for them? What's the apprehension? Why the apprehension? Where does that come from? And then usually they're telling me, well, I didn't have to do this. So I'm like, okay, so when I was growing up, and that excuse will come up, and I'll say, okay, so years ago, when people were growing up, they didn't have cars, they had horses, and they had donkeys, and they had ox. Should we still be utilizing that system if we know that there's something better, right? Years ago, some of these vaccines had certain ingredients in them that were not helpful. They didn't kill you, but they weren't helpful as the ones that we have now. Should we still be utilizing systems that we know that are not as beneficial? And where does this come from, right? And so that's the other piece that I think I try to utilize with people. Like, if you know there's something better, why not try that option? Why be so adamant? Why the negative lens on people who utilize this system of healing? Why is that considered bad and weak? Where does that come from? So I try to be respectfully curious and asking people to help me understand their perspective.
Yeah.
And then I often do what if, but what if it was helpful?
Mm-hmm.
Right? Then
Yeah.
what? So those are the ways in which I try to challenge and have an understanding, or help people understand their own apprehension with regards to therapy. With the understanding that still, if that person is really adamant about it not working, it won't work.
Yeah.
Mhm.
Yeah. Thank you.
You're welcome.
Are there any more questions for us? All right. In the meantime, I'd love for you to tell
I
us
just want
about.
one, I don't have a question. I just have a comment. Sometimes, especially in the church, things happen. And the first thing that we say is things like, oh my goodness, maybe it would have been good if that person had been seeing someone, or or um or something happens in the church where we wish that there was more intervention or more oversight, because it only what happens is that things kind of like foment until it becomes something that is either so critical that either the police have to be called, or the person is committed to a hospital setting or something like that. Why am I saying all this? It is better for us to be open to these sorts of avenues of maintain, because just like anything else, your brain is an organ. It is a part of your body that can break down, and things can happen to it. Sometimes it's a chemical imbalance. The doctor is in a better position to talk about this more than I am. And so, but we tend not to believe, and the tendency is out there that nothing can happen to the brain. And if it does happen, you need to kind of like self-fix it. All right. And so, especially because we come from this usually West Indian background, where the attitude is to be stoic, to be self-reliant, and taking care of your business, and you know focus and take care of that, and so on and so forth. That kind of mentality and that kind of reasoning causes a lot of problems. And just like any other situation in the church, we have people with mental you know situations going on, and no one knows about it until it becomes something so big that we all have to know about it. And so it's very important that we demystify this entire thing and allow people to understand that if you need to go see someone, you should, and there's nothing wrong with it. And we should, let's get rid of that stigma. Let's talk about it. We don't talk about it from the pulpit. We don't talk about mental health because it's sort of like, anyway.
Thank you so much.
Yes, I really do appreciate you sharing that. what you just stated is so true. It is important for us to be intentional about preventative care. It's really important for us to be intentional about recognizing you would not, most likely would not tell someone who has diabetes not to take insulin if they needed
No.
to. We would not tell someone who is dealing with cancer, oh my gosh, you should not go see an oncologist. Do not go see the oncologist. Why would you do that? You should just take this, these vitamins and just, you know, see what happens that way, like, and just pray about it. We don't normally do that with other illnesses or other diseases. We don't do that. Uh, and so why is it okay for us to do that with depression? And we know it's leading disability in the world. We know this for a fact. And so we need to be very mindful about what it is, what messages are we putting out there, especially from the faith-based community, right? About making sure that it's okay to ask for help. It's essential. We come from a collectivistic oriented society as Caribbeans. Majority of the Caribbeans, we tend to be collectivistic. And so we know that we need to support one another, right?
Mhm.
But then when it comes to mental health issues, we're not as open to utilizing a collectivistic lens. We become more individualistic, and that becomes problematic.
Very much so. I also think that we have to be conscious of our language and how we speak as it relates to mental health. Because oftentimes, especially around our young people, because oftentimes our language is so negative that even if someone would consider, but because of how we speak about it, it often allows people to be hesitant to be able to embrace it. So I think the way we speak about it in our homes, how we speak about it at church, wherever we are, we have a way of, oh, that person's crazy. We
Right.
also have to be careful of how we, make comments because, believe it or not, these are some of the contributing factors to why people are very much hesitant to embrace this. I, for one, believe that it is essential. I know it has helped me. The same way you have expressed anxiety, I've had challenges that I've had to make decisions as to what I was going to do about it. And I'm happy that that was a decision I made. And I believe I'm a better person as a result of it. And with that being said, I would love for you to share with our audience just your practice, where you're located, if
Okay.
you have online services, etc., etc., etc.
Yeah. So my practice is I have a private practice, small private practice here in the upstate of South Carolina. It's called Vadreens Healing Services. Um, now, I wouldn't be able to service anybody in the New York area because I'm not licensed in the state of New York. I am licensed in Colorado, South Carolina, North Carolina, and Florida.
Okay.
So, if a practitioner, in order for us, the way we have it for licensed marriage and family therapists and licensed practitioners, therapists, you can only practice in a state that you're licensed in,
Mhm.
right?
Thank you.
So, yeah.
All right. Well, we have family members
Okay. Okay.
who live in other states, and
Mhm.
friends. So having
Yes.
this information is definitely beneficial. I'm also aware from looking at your bio that you lecture at University of Massachusetts
Yes,
Global.
the online program. Yes,
Mm.
I do.
Um,
Yes, in the
Quick
marriage
question
and family
about that.
therapy program. Mhm.
Mm. Do you notice that there is a growth in interest in this field?
Yes, there is a growth. I'm very thankful that there is a growth. Uh, so there are people who are wanting to know more about how to support individuals and families to heal, to deal with mood disorders, any psychiatric issues. There is a growing number of individuals who are entering the field. So I'm really thankful for that.
Awesome. And one last thing, this is just about me and my curiosity.
Okay.
So I know that there's been conversation about AI and how AI will be impacting many careers. And one of the conversations we've been having with a friend for the last couple of months is whether or not AI would be able to take over this profession. I know that in the medical field, what's been happening is that we have doctors who are now working with AI companies to train robots to, I know, to be able to do diagnosis and treatment. So, what are your thoughts on that, just as an aside?
Okay. So I am very biased. I am not a proponent for AI. Um, the way I understand AI, I think it can, so let me put it this way. AI can be used as a tool. I think
Hmm.
that is fine to be used as a tool. The problem that I have is people thinking that it can replace people. Um, AI can never say, I know how you feel. If it does, it is lying because it doesn't know how you feel because it's not human. It cannot have a human experience. And
Hmm.
that is important. There's a lot of nuances that individuals have that help with dealing with the complexities that people are coming in with in therapy, right?
Yeah.
So for me, I think it's okay to utilize AI as a tool, but I think there's a lot of issues with thinking or believing or hoping that AI will replace a human being.
Yeah.
It doesn't
I
have the
know.
ability for creativity.
Yes.
And then
For
the other
sure.
thing of it that people think that it will be more objective, but in actuality, it's like what you put in is what you're going to get out, right? We know human beings are biased, and the individuals who are creating these systems
Have their
are human
biases.
beings and they're biased as well. So trash in, trash out. So that's important for us to take into consideration as well. So I'm okay with utilizing AI as a tool, but I do
Mhm.
not believe it would be wise in any way to replace human beings because there's certain things, like I said, that we can understand and assess that are nuances or complexities to the human experience that AI will not be able to assess and understand, but yet will make a diagnosis or will say this is what you need to do,
Mhm. Mhm.
and that won't work for the client overall well-being, if you ask me.
Thank you for obliging me on that one.
My pleasure.
Thank you so much for presenting this evening. I really, really appreciate you coming. On behalf of our Living Hope family and Faith and Family Circle, we're really grateful. And I hope this will not be the last that you will come on.
Why, thank you. I
I
would
hope
welcome the opportunity to come again.
awesome. I hope we'll make lifelong impact and interaction so that as we grow and as we expand, we'll be able to call on you at any time as long as you're available. Thank you so
Yes,
much.
please do. Thank you. Thank you, everybody. I appreciate your Faith and Family Circle for inviting me tonight. Thank you.
Thank you. Thanks everyone for coming on. We look forward to continuing on our conversation and our discourse on mental health. And just to inform you that for our men for the month of June, even though we have a 5 week focus on mental health, for June, we're going to be focusing on our men for a little bit. And we're going to be looking at men's health, mental and physical. So please be prepared to share the link as we get ready to talk about our men and encourage them mentally, spiritually, and physically. Thank you all for coming on. Have a good evening.